I don't think that today's speaker needs any introduction to most of you. Jim Donahue is the Division Chief of Pulmonary and Critical Care Medicine. His tenure here began when he was a postgraduate resident. So it goes back further than most of us want to think about, and I know that Jim wants to think about it. In fact, your tenure may be longer than anybody else in this room right now. Right. I think Norton might date back that far, yeah. But at any rate, Jim's career has been very, very productive in a number of areas, including the career of a clinician educator, a clinical researcher, and an administrator. And he's developed a national and international reputation in pulmonary diseases, particularly in the area of COPD, alpha-1 antitrypsin deficiency, asthma. And today he is going to discuss a topic dear to his heart, and that's COPD. And as you probably know, Jim is on multiple national and international groups in terms of setting quality of care standards and treatment of this disease and doing clinical trials in this disease. So, Jim, I'll turn it over to you.
Thank you, Andy, and it's always a pleasure to come to Grand Rounds and to talk with all of you and get your questions. My title today this is from a talk I gave at Hopkins a couple of months ago on, was asked to speak on lessons from some of the large clinical trials, and in particular in COPD. I'd like to focus on, where we're going. Now, the first thing I'd like to do is, I don't have the slides, but just to give you a little background, in North Carolina, like all states, participates in the Behavioral Risk Factor Surveillance Survey, a 90-question item, basically from CDC, but we're able to get 6 questions, our COPD task force in the state on the BRFSS survey, just to give you a little bit of the impact that of people that we take care of in our state. There are 14,000 respondents, and there were 6 COPD questions. So anyway, from the survey, about 6.2% of adults in North Carolina state they have a physician diagnosis of COPD. Well over 70% had tobacco exposure, which is fairly typical. More women than men. Huge correlation, again, from the questionnaire, and a lot of these are being worked up right now. A lot of depression, a lot of cardiovascular disease. Patients sign their health and call it poor. It's very similar, overlaps with diabetes in the sense of poor health. So a big impact in our state, but it's interesting, at the end of last year in September, I had the privilege of throwing out the first pitch at a Durham Bulls game, if you can believe that. They actually didn't let me throw the pitch because they're afraid I'd kill somebody in the stands. But anyway, they handed me the ball. But anyway, it's ironic that the first time we have a relationship now, the COPD Foundation in the United States with minor league baseball, and we screen people in the ballparks and provide them with information about COPD. So we had 6 pulmonary function techs from Duke screening people, and we screened over 100 people, and were able to answer and questions and talk to them. Now, having said that, there's lots of controversy in the large clinical trials. The first was a recommendation a couple of months ago in the Annals not to screen asymptomatic smokers around age 50 with COPD because the indicator of COPD that we've been using, namely an FEV1 FVC ratio of 0.70, or the least, the lower limit of normal, LLN, of which 5%, misidentifies a fairly substantial number of people, and so the risk of that is overdiagnosis. And that's kind of funny. That's the interpretation, because we always have felt that many people who suffer with COPD have not been identified. So what I'd like to do is not take on that controversy, because that's way outside of my knowledge and expertise, but I'd like to focus on a couple of questions, and particularly the one that we were heavily involved with, are anticholinergic safe, because a lot of the data that were used in those meta-analyses were generated here and other places. So first of all, what we have standardly used in COPD has been the FEV1, and I have evolved in my career and morphed. I do an awful lot of work with the Food and Drug Administration, and working with the FDA, because the FEV1 is reproducible and everyone can do it and everyone does it quite well. That really is the outcome measure that leads to the licensing of drugs in the field of COPD. That's far from perfect. As shown here, we have a correlation between the St. George's and the FEV1, and it's all over the place, the correlation, as you can see. So other outcomes in COPD, like quality of life, mortality, the exacerbations, track a little bit differently than the FEV1, but again, it's still good enough, and recently exacerbations have come to the fore as a second standard that can be used. But there's been a very nice review in the European Respiratory Journal in October last year on outcomes from pharmaceutical trials in the field of COPD. So we have the traditional value, the FEV1, and it loosely correlates, far from perfectly, with severity. We use it for severity as the goal guidelines, but also mortality. It'll track that, and I'll show you in the last slide. And then we became interested in, of course, composite indices to describe this disease as well as other diseases. So BODE includes body mass index, FEV1 is the O. We have a dyspnea scale, a 5-point Likert scale that ranges from no shortness of breath, or I'm so short of breath I can't get out of bed, and E is for exercise, and that's the simple 6-minute walk test that you're familiar with that's used to license drugs in the field of pulmonary hypertension and lung disease, but so far not used in our COPD work. Chest CT scan is really a fascinating area in terms of an outcome, and I was discussing with Robert Aris this morning a really important paper from Japan. You can, again, if you do it right, one can, when you look at a CT scan, you can look at the attenuation in grade COPD, and we use that now to look at some of the interventions that we do. But also that chest CT, by looking at the bones, can provide really very, very good information on the very important, the bone disease tracks right along with the lung disease with this condition. So it gives us a good way of looking at that. We have a 6-minute walk test, which also, remember, all our patients with COPD have comorbidities. Many are diabetics. A very large number have cardiovascular disease. And so we're really interested in our patients' functionality rather than some lone phenomenon happening in the chest. So the 6-minute walk is good, but it's not done well. It's good for looking at things like oxygen desaturation, but actually looking at that distance. Only people who are walking around 500 feet, 600 feet, that's useful. When it gets a lot lower than that, it's not useful. And when it gets higher, when people are pretty fit, it really doesn't do much. And it's been an outcome in all the clinical trials. Andy was talking about how long we've been doing things here. We go back to the early 70s with the clinical trials program in COPD, and we've never been able to show that any drug can influence that parameter except in pulmonary hypertension. So drugs like bronchodilators, inhaled steroids, and the biologics that we'll talk about this morning have not been very effective. And now I want to take a moment, though, and go into a new parameter, inspiratory capacity, which is perhaps a little more meaningful. Now, first of all, we mentioned on the left here, we have the FEV1 stages from stage 1, 2, and 3 here, and showing not a very good correlation with survival, but when you use the composite, the BODE index for 4 quartiles, we get a little better separation. So clearly FEV1 is not good enough. Now, one of the parameters we're beginning to report over and over again is the inspiratory capacity. What makes our patients short of breath is not the resistance and FEV1, but rather it's the air trapping. With the pathophysiology of COPD in particular, with emphysema, inflammation, and remodeling of the smaller airways, air is trapped in the chest, and we begin to increase the residual volume and total lung capacity. Now, one of the tests that we can do rather easily without having a body box or a doing a helium dilution is the inspiratory capacity. And it's becoming increasingly important parameter. And what you do is a number of tidal volume breaths, and you take a big breath in, then you blow it out down to residual volume. And here's the inspiratory capacity. And we do more breaths than this here, but that's the difference. That's the delta. And you can see it over on the other side here with the residual volume, the amount of air left in the chest after a complete exhalation, expiratory reserve volume, which is a parameter that'll change with weakness and with obesity, your tidal volume, the IRV, and the total lung capacity. Now, we know that our patients with COPD have both static hyperinflation and will have dynamic hyperinflation when they exercise. And similar to the ICU, hyperinflation or overinflation is a bad thing. Whereas in the ICU, it's associated with barotrauma and inflammation. We also think that we have, and I'll show you some of the early data as it's emerging, this overinflation correlates with the poor cardiovascular performance and also is related to inflammation. So we have the normal, then mild disease here, and you can see moderate and then very severe as we go. So the inspiratory capacity up here is being encroached upon, and the volume available for our patients to breathe is becoming less and less as we retain more and more air. So these markers are very, very important. However, the Food and Drug Administration has never approved a drug based on these outcomes. In fact, a couple of years ago, I was trying to present data to the Food and Drug Administration on the need to incorporate lung volumes, and they just hadn't vetted enough large data sets that they felt comfortable that these tests were done sufficiently well by many centers that they could license the drug. So it's still in I think, a process of moving along. The problem with the IC is we don't have normals described yet for the parameter. And what we try to do, and this is a slide set Barcelli and I are working on together, he's trying to what do you call, normalize it for the total lung capacity. So what we're looking at now and trying to make this a little more meaningful for clinicians is the inspiratory capacity. If you have a total lung capacity, that kind of a normalization. And we can see people who have a bad IC, a low IC, and hence a high ratio do poorly with exercise endurance. So here's the peak VO2 exercise capacity, and when the inspiratory capacity is encroached around, whether you normalize it or it's diminished because of air trapping, that really correlates with poor exercise capacity. And it may actually predict maybe one of the most important factors in death. And this is really data that are just beginning to emerge. What's so bad about air trapping? Now, clearly, I've done this 100 times here. When one inflates their lung to total lung capacity without exhaling and tries to breathe, you can feel how short of breath you are. And so clearly, hyperinflation correlates with shortness of breath. But what is beginning to become apparent is the pejorative effects of hyperinflation on cardiovascular performance. And this study by Fasol and al. in the European Respiratory Journal just late November shows, and we're looking here at oxygen pulse at rest or in peak exercise, and here is the delta. And these are COPD patient groups over here, and this is the group with a very low inspiratory capacity over here. We see the resting oxygen pulse is low. We see the peak exercise is also low, and then the delta down here. And what people are beginning to hypothesize is that hyperinflation, and it's hard to do the echoes looking at the right side of the heart and the function of the right side of the heart in COPD with hyperinflation is somewhat difficult to do. But it appears that hyperinflation really does impede the preload and afterload and cardiovascular performance. And as everyone knows, our patients that you all see in the clinic and on the wards here suffer not only with lung disease but cardiovascular disease. They go hand in hand. Many of these folks, of course, also have diastolic dysfunction and other abnormalities. But there's really an important interaction here between cardiovascular performance and air trapping. Secondly, Peter Barnes is just beginning to show that, and talked about this in Berlin last month, or in November, that he's been able to show that in patients with hyperinflation, they can produce all kinds of inflammatory changes in the small airways of the lung, and evidence of that spilling over into the systemic circulation. Now, many of our patients, just coming back to the practical world, again, we give albuterol to, and in clinical trials, reversibility is now being defined by as many as 4 puffs of albuterol. And we define COPD, the gold guidelines for the residents, by the post-albuterol lung function. So again, even though it's a terribly flawed parameter, obstruction is defined as an FEV1-FVC ratio of less than 0.7, until, again, we change the organizations change that to the LLN, but right now it's still 0.7. And then gold 1 is an FEV1 of 80%, 2 is 50 to 80, or moderate disease, 3 is 30 to 50, and 4 is less than 30. And what is being shown here in this is the FEV1 change with a little bit of hyperinflation or mild, and then moderate, and then severe here. And if you look at the FEV1 ratio, we don't see much change. But if we look at our patients with the IC, and then better yet, if we normalize the IC to the TLC, we see that in people that are severely hyperinflated, the patient gets a benefit from the drug. Now, how does that happen in the clinic? Now, we don't encourage you to do multiple spirometries, but maybe whatever the organizations require. We certainly need it in the outpatient for diagnostic purposes if you're going to call a patient a COPD. But we don't really use it to look too much at a response to an agent. It's much more important how our patient feels. And many folks who we give bronchodilator therapy to us come back and say, I feel pretty good, or I feel somewhat better. Nobody with this disease feels great. I'm not a Pollyanna. I know, treated thousands of these people. Nobody feels good. No drug is that good. They're good, but not great. But anyway, the reason that a lot of patients probably tell you they feel better is this changing on the volume here and not reflected so much in the FEV1. And that probably will become a parameter of interest to the licensing process of drugs down the road. So we might see changes in these parameters that we don't see in the FEV1, but this is a work in progress. Before I get into the very hot issue of late last year, or anticholinergic safe, I would like to back up and say we have a number of other techniques that are available to deflate the lung. First and foremost, of course, anytime we talk about COPD, we're talking about smoking cessation and trying to prevent further damage. If a patient at age 50 is already obstructed and they stop smoking, their disease will continue on. It'll continue on at a slower rate of decline, but they have a chronic disease. That inflammation, we know that from the pathology specimens from the lung volume reduction surgery studies, the National NET trial, that inflammation persists, although perhaps not as bad as if they kept smoking. So this is still a target, hyperinflation. There are surgical procedures that were popular a few years ago, like lung volume reduction surgery, that had risks and benefits and outcomes that have been really quite clearly described now. For those who have disease involving the upper lobes, so we have localized kind of disease with low exercise tolerance, at 5 years, the survival is better, the exercise endurance, the quality of life, and the Bode index are better at 5 years. Not a reality. Last year, only 250 people got that operation, whereas years ago, thousands of people were getting it. So physicians have been loath to refer their patients with that procedure. But what else do we have? We have a number of bronchoscopic procedures, which I'm sorry to say have not passed muster at the Food and Drug Administration device section, simply because it's been very, very difficult to show benefit. And there they are, valves that are put in, one-way valves, and there are a number of them, and they were reviewed late last year, and the results have been inconsistent. The valves, the idea is to impede airflow so that the lung absolutely collapses behind it. And so that may or may not see the light of day, although there's been really a lot of effort with those. A lot of patients have had pneumothoraces and complications. On average, they do work, but the magnitude of the change, and I actually saw the data for the FDA, the magnitude of the change is quite inconsistent and modest, and there's a downside. So I don't know how that's going to work. There's also another procedure called a stent, airway bypass, where multiple stents are put into the airways, into the emphysematous lung as a way, it's a communication also to deflate the lung. Again, will that see the light of day? I don't know. And now there's biologic, I just want to mention this to you, biologic lung deflation. And so you're interested here in destroying the surfactant of these hyperinflated areas so that the lung will ultimately collapse. And that's being done basically with fibrinogen. It's an interesting technique. You first put the material into the lung, and then ultimately you hope the lung will collapse. And that procedure is in its infancy, but may have some attractive features. And these are all attempts to do what we're trying to do with the medications, reduce the volume of the lung. And we'll just have to see. Now, I want to touch on another very important topic that was very, very hot late last year. The platform for all therapy in COPD from the ATS and GOLD guidelines and all the various learned bodies was inhaled long-acting agents. And once a patient becomes symptomatic. And the idea behind was that was easier and it was more effective than multiple doses of short-acting agents like albuterol and ipratropium. And the usual platform was tiotropium, the antimuscarinic, and the reasons being that in COPD, cholinergic mechanisms are more important than adrenergic mechanisms in contributing to obstruction. And we had a long track record of using short-acting anticholinergics, ipratropium, with patients with COPD, both in the acute setting in the hospital as a nebulized form and as outpatients. And so tiotropium basically was our platform. All was well until late last year in the JAMA and in the Annals, two meta-analyses, one on ipratropium and tiotropium by Singh and Kurt Furberg, and then a second one in the Annals, Kevin Weiss and others are involved with that. Then we had a response from the manufacturer of tiotropium, and then the Uplift study was presented at the ERS and then published in the New England Journal of Medicine, and we participated in many of these trials at UNC, and we were investigators with the Uplift trial at UNC. Now, I don't know how well this projects, but this is the data from Dr. Singh and Dr. Furberg, and basically we just look at the bottom here, we have the overall, and we're looking now at cardiovascular outcomes, cardiovascular deaths, myocardial infarction, and stroke. And on the top here, we have tiotropium in all the studies, and then ipratropium, and then Dr. Singh and Dr. Furberg, the overall, the Foster graphs here. Now, please note, in the tiotropium and the ipratropium here, and that was very, very difficult intuitively, because after all, for years we had been taught that beta agonists were the high-risk class of drugs for patients who suffer with cardiovascular disease. There was always a feeling, and I had it, and maybe I'm wrong, that, gee, this class, the anticholinergics were pretty safe, and physicians preferentially used them in cardiovascular patients. I'm sure you all did that in the room here. So this obviously was a source of some concern. And there's a couple of errors in here I want to bring to your attention. Now, in 2002, we published a study in CHEST of tiotropium versus salmeterol, and tiotropium did very well in that study. 2 years later, Vito Brasacco in Thorax published the data, but it included all my patients, and there was no reference. And you can see the weight of that study, 9.2. It's a problem. Now, there was a big hullabaloo. I had nothing to do with that second paper, and it was a mistake, obviously a major mistake, but it's really misled a number of meta-analyses, even though it's been retracted and there's all kinds of explanations and what have you. And unfortunately, the authors of this paper fell right back into that trap, as did Shelley Salpeter in her meta-analysis, with the absolute opposite conclusion that anticholinergics were very safe and the beta agonists were harmful. Now, ipratropium down here, there was some evidence way back in the early 90s in the Lung Health 1 study that anticholinergic ipratropium had a slight risk of more cardiovascular events. It turns out, though, in careful analysis of that study, that most of the people weren't taking the medicine, but it raised some issues. And you can see I didn't put down here the Annals study, but the ipratropium data is also on this side favoring the control group. So a very, very disconcerting, allowing for that one error in there, which has a small impact, but doesn't negate this meta-analysis. Secondly, this is just to make it easier to see. This is cardiovascular deaths, MIs, strokes, and all-cause mortality. And the number of trials, so this is a fairly robust data set, at least in the field of COPD, is 5,430. I remember taking this drug and making the presentation at the FDA way back in 2002, and we got it approved we're successful as a bronchodilator, but we really already had a very large data bank. But these are high numbers. Look at that, the relative risk, 1.8, p-value 0.008, and the 95% confidence. That scared you. And then stroke, of course, was not, but still. And here we are giving this drug out regularly. So many of my colleagues in internal medicine who I share patients with, both here and around the state, would often in their letters on WebSys to me and the patients coming through, they would defer the decision to me whether or not, we should take the patients off this drug. Now, most of my work had been on the efficacy arm, and it really had a dramatic impact on FEV1, hyperinflation, both dynamic and static, exercise endurance, quality of life, exacerbation. Very, very good drug. So we had to balance then the benefits of this very good drug versus this risk. And these are, Dr. Furberg, as you all know, in cardiovascular, although he's very opinionated and he's way off on one side, he's a very good investigator, and no one ever would deny that. There's other data coming in. This was late last year, and it's just an observational type study from Canada in 7,218 Canadians from a data set. 14% died. In TIO, there was patients on TIO were less likely to die. Coming back to our initial hypothesis, that's probably a good thing to deflate the lung, and it'll enhance cardiovascular. And then this is, I would hesitate to put out something coming from a company, but this actually went to the FDA and went out as part to all the IRBs, and it incorporates now all the data in the SING trial as well as the UPLIFT. Now, UPLIFT was a 4-year study done in over 4,000 patients, and it was powered on changing the slope of the decline in the FEV1. But it also, although it was not a primary outcome like TORCH, it had the ability to look at mortality and cardiovascular, what have you. Those 4,000 patients from that trial, which is now published, and as you know, there's a lot of questions, a lot of papers and commentary. It's in the New England Journal of Medicine by my colleague Don Tashkin. 30 trials. This is from BI and Pfizer, the manufacturers of the drug, and their meta-analysis, which the FDA had and ultimately agreed with, the all-cause mortality, when you add UPLIFT to everything else and you make the correction for the Brusaka study, the relative risk was 88.88. The 95% confidence was 0.77 to 0.99. It doesn't have a p-value of significance. Mortality due to cardiac disease, that was all cause 0.77, and stroke still stays 1.03, not significant. MI, the relative risk, 0.78, 95 confidence, 0.59 to 1.02, and that's pretty much the data that the FDA are vetting. So basically, what are we to say to this, and what do we say to our patients? I think with this UPLIFT trial, and there are questions about the UPLIFT. Let me just say, if you look at what happens we had a washout period at the end of the study, and there's some excess mortality on the treatment arm in that washout period at the end of 4 years. So that is a big, big question mark. I don't know what to make of that, what it means. But if overall the mortality in that study was improved, the all-cause mortality, by the actual use of the drug. So all I would tell you right now to stay tuned. My belief is I'm influenced by these data, many of which we generated, that the drugs are safe. But what happens now? What would we use preferentially in our patients? So many of our patients who have cardiac disease. What bronchodilators do we use for their dyspnea? We can't use theophylline. Short-acting beta agonists are not very attractive. Short-acting anticholinergics like ipratropium are not very attractive. Dr. Salpeter has published that long-acting beta agonists are not safe in her meta-analysis. You're looking at the same data, and then we have this. So in my view, again, if we can, again, we have to discuss with the patient the all-cause mortality. I always mention the Furberg article. I mention this data too. In my opinion, I think the evidence, the preponderance of the evidence still favors the treatment with this no one ever argues about its effects on outcomes that are relevant to the field of COPD, but that mortality issue still lurks in the background. I don't think there's a signal there, but there's an awful lot smarter people in the room here who are experts in doing this, and all I do is I give the drug to patient and I measure their FEV1 and record it. So, but stay tuned to that. And I think right now the preponderance of the evidence argues for safety, but there are still some questions. I wanted to review this also as a large clinical trial. This is the INSPIRE data, a 2-year study conducted by Glaxo. So it has their drug, the 500/50 fluticasone salmeterol versus tiotropium. And this study was powered on exacerbations, healthcare utilization exacerbations. So that meant that the outcomes of interest are an oral steroid or an antibiotic written by a healthcare giver or a unscheduled emergency room visit requiring hospitalizations. At the end of the day, it was a wash in terms of the annual rate of exacerbations and the rate ratios, as you can see. What about mortality? Was there a signal? This study was interpreted by Glaxo as showing the top here we have a slight, and the study was not looking at mortality, but there are fewer more events in the TO arm than the combination of the LABA ICS. But the study was really not powered to look at that, and some have interpreted that as showing a survival advantage or some slight advantage with the inhaled steroid ICS, like the TORCH study. I don't know what that means. I think the numbers were too small. Study was not adequately powered, but basically it's a wash. And then the reason I put that study in there is everybody always asks, what do I use first? The ICS LABA, or do I use the anticholinergic platform? And again, it's your choice. There really aren't much in the way of differences when you do an excellent head-to-head comparison. These differences are minor. On the primary outcome, no significant difference. That's what the study was designed to look at, and there is no difference. So you're free to choose whatever one you want if you choose to use these agents. And I would think that the efficacy in this chronic disease with a lot of morbidity favors intervention with the medications. Now, another important outcome is disease modification. This is reflected in the annual decline in FEV1. We all lose 20 mLs a year. We know from Lung Health 1 that smokers with COPD who continue to smoke lose 60. Ex-smokers are 30. Our NIH registry for alpha-1 deficiency that we did here years ago and many other places across the United States showed possibly an effect with use of a replacement therapy. Now, the two studies at the bottom when I wrote that editorial were ongoing, and I just want to report on them. Since this measurement supposedly reflects disease modification. So the uplift was powered on the change in FEV1, slowing the decline from the usual 30 to 40 mLs a year by at least 15 mLs. And that was based on the one-year study by Tony Ansoeto here, and again, UNC was in this all these trials, showing a 10 milliliter change in the top here, if I can find my pointer, right here, and 40 below baseline down here. So that's a nice difference. And that's how this uplift, and again, the study being powered on that to change that slope, it failed. Okay, that's the bottom line. It didn't do that, even though it did other things that were very encouraging. Now, from uplift, there was a survival advantage on all-cause mortality with tiotropium after 4 years. Also, there was changes in quality of life, fewer exacerbations, and so the secondaries were all very good. Well, why did it not do what it was supposed to do? Because, again, Graham-Barr in a meta-analysis in thorax looked at 9 trials. TIO seemed to change the decline in FEV1 by 30 mLs. Why it did the other. And the reason's probably here. This is from Bart Celli, who we had do grand rounds here a couple of years ago. And this is a second look at the data from the Big Torch study published in the New England Journal of Medicine. And we have a placebo here losing 55 mLs per year, and we have the various monotherapy arms, and we see here the combination of fluticasone, salmeterol, changing the slope, and its study wasn't powered on that parameter, it wasn't powered on mortality, but it really seemed to have a good effect on changing the disease progression. Well, what happened in the uplift study was that the study was open, and just about everybody in the trial was on this combination. And so perhaps the reason that the study didn't show much of a change in the slope was that, again, the patients were already on double therapy. For those naive patients not on double therapy, there was a response in changing the slope of the FEV1, as there was in most patients in the first year. Now, interesting, lots of money spent in lung disease. We have to see every patient, do repetitive visits, do exams. Very, very expensive. We can't use, insurance data very well because the outcomes really are mechanical function. And so perhaps an explanation was because the patients were already on different therapy. Most other drugs that we have tested, again, to look at outcome disease modification, it seems that we need 3 years of data to run these trials. I wrote an editorial. This was another failure with the antioxidant N-acetylcysteine, because COPD is a disease of oxidative stress. Now I want to just switch hats for 1 minute and talk about inhaled steroids. Inhaled steroids are not approved in COPD. One of the dilemmas we face in the clinic is we often can't tell whether a patient has asthma or COPD. And if you're a person who believes in the Dutch hypothesis, to you it doesn't matter because you treat both the same. But maybe not. We know that in asthma, inhaled corticosteroids are highly effective therapy. And for the second time, we had another AdCom at the FDA in December. I didn't participate at this one, but I did help in the briefing documents. Once again, monotherapy with long-acting beta agonists, salmeterol and formoterol, was really felt to be not downright harmful. And the companies all had to go back and do meta-analysis on every patient they ever ran through. And clearly there's a death signal with those drugs as monotherapies in asthma. It's rare, but it's there. And I think the risk difference, I think is the parameter they used, was clearly that way. There was no such signal when you combine the two groups. So there is some importance. Now in COPD, inhaled steroids fail. In 2002, I presented fluticasone. Our studies with before the FDA were turned down for approval because it didn't work. A lot of side effects and the change in lung function. Again, our parameter was 50 ml. So we defined the minimal clinical important difference in lung function in a study we published a couple of years ago is 100 mLs on that trough. But I'm trying to now define what the inspiratory capacity is. So anyway, Don Sin did a review of all inhaled steroid trials, and it looked retrospectively, looking at all those trials, that there was an 8% improvement in survival with inhaled steroids, and that would include Euroscope, Copenhagen, and all the big trials. Lo and behold, however, when the TORCH study, the TORCH mortality study was done, the primary analysis here is all-cause mortality, lung cancer, heart disease, and COPD. It almost makes it, but it didn't. Here's the adjusted. This is the one that counts after the interim analysis. It just fails. But what I wanted to talk about was that the inhaled steroid in the prospective study, the survival was worse than with placebo. Okay, so again, what we learned, even looking with very good meta-analyses at retrospectively at the data sets, when you look at them prospectively, the results can be divergent. What else about inhaled steroids? There's just a couple of things I wanted to say. There's two important meta-analyses that were published late last year. This one, the second one by Drummond in JAMA. And looking at what is the word with inhaled corticosteroids. And first of all, when we look at mortality here on this column, these studies, in fact, there is no significant effect on mortality when one puts all the studies together. There is an effect on exacerbations, albeit it's not nearly as good as perhaps with the combination of inhaled steroid and long-acting beta agonists, and perhaps the long-acting anti-muscarinic agents like TIO. So there is an effect on exacerbations, but it's not nearly as powerful. What I wanted to, it doesn't really impact St. George's. I wanted to come down here to the pneumonia signal. This is important, it's new. Whereas inhaled steroids and inhaled steroid LABA combinations reduce exacerbations by 30%, there is a signal on pneumonia which is beginning to be seen, and I just want to quote from the, so I don't say it wrong, from the Drummond meta-analysis. So first of all, inhaled corticosteroid therapy, after reviewing 11 trials, 14,000 patients, does not affect one-year survival. It increases the risk of pneumonia, the relative risk 1.34. Who are the subgroups? The high ICS doses, so again, lower is better. Those, believe it or not, shorter duration of use had more pneumonias than people on them longer. The lowest baseline, FEV1, the highest risk group, which is exactly who would be using them in, even when you combine it with the LABA, the relative risk of pneumonia is 1.57. And one thing that was very reassuring, because Robert Harris, again in our group, is a real expert on this, ICS were not associated with increased fracture risk. So that's kind of reassuring. So what are we to take away from this? Well, there's a benefit by fewer exacerbations. That's 30%. The exacerbations drive survival, quality of life, and all the other parameters. The pneumonia signal is in there. It's higher in people over 65. It's higher in people with higher doses of inhaled corticosteroids. And so it's something to be aware of. Perhaps there's some changes in the innate immunity that I think one would expect to be coming with inhaled steroids. And it warrants careful watching. Now this database is very weak because these are adverse events that clinical trialists check off. There's not a lot of x-rays or CAT scans or what have you, but it is there, it's real, and randomization, you're going to see it because that's a big effect. A new drug is a combination of budesonide and formoterol in combination. I'm just showing an effect on, a modest effect on St. George's quality of life. In their data set by Don Taskin here, there seems to be fewer pneumonias. If we look across the top here and compare it to placebo and formoterol, does that mean it's better? I wouldn't be prepared to make that statement at this time. I think it could reflect maybe lower doses or what have you. So just be careful with that. If your patient has a bout of pneumonia, obviously, do you go back and use the drug again? I think that would be very, very difficult to do. Let me just end up. I wanted to end. These are what's coming into 2013. Really nothing in the field of COPD. Triple therapy is what's out there, and I took it out here. Timelines of when of all these new medications. There's a new, what's called entity called the MABA, which is an anti-muscarinic LABA in one single drug. Again, whether that's an advance or it's just a trick, It's very hard to get a lot of good information, but this is triple therapy. Inhaled steroid, long-acting muscarinic antagonist, long-acting beta agonist. It didn't do much in the Canadian Optimal trial, the 3 drugs, but no, there was really not much in the way of escalation of side effects. This is the triple on FEV1 versus monotherapy and dual therapy. And over here, St. George's. So that's all you're going to see. I took out of there's a lot of biologicals being looked at, but a word of caution, we studied and published the infliximab data, and we exposed, I mentioned it before here in Grand Rounds, it's published in the Blue Journal, 232 patients. We had 9 malignancies in a year, so that's not going to work. IL-8, the monoclonal antibody we worked on here, it didn't work. We worked on chemokine receptor antagonist biologics. They haven't worked. So it's been pretty frustrating as we go down that pathway to try to find something in the biologics. So coming back, what do we have? I think looking at the guidelines, and I wrote the last mix-up on this for the American College of Physicians, we're still I think, in an era where the guidelines, if a patient is symptomatic, after we've done all the right things, of course, that's smoking cessation, number 1, 2, 3, 4, 5, lifestyle modification, flu shots, pneumovax when appropriate, exercise, so vital to the survival of our patients, good diets, and the role of dietary antioxidants, things like that are still being elaborated, but extremely important. This is a disease, the comorbidities probably are equally as important as anything I can do. So obviously we have to treat the heart and the sugar and the blood pressure like you all do in internal medicine. But we're still going to come down to then the treatment of the patient. What do we do? And we can give them our short-acting rescue medicines. But if they are symptomatic and their lives are pretty miserable, then I still think that we would stick with the present day. The best evidence still suggests a long-acting muscarinic platform, or perhaps equally a long-acting beta agonist, ICS kind of platform. And then we would add different agents onto that. If you want to improve lung function maximally, the add is probably a long-acting beta agonist of 2 different classes. If there's exacerbations, one would consider the ICS. With the ICS, you have to be aware of the pneumonia signal. That means probably more antibiotics for exacerbations, not just prednisone. And these are, again, exacerbations that are occurring in people down the pathway where they're likely to have bacterial with strep, H flu, and MCAT, rather than a viral or environmental exacerbation in people who enjoy pretty good lung function. They would be similar to the general population. So not a very, I think, encouraging story. A lot of, even the good drugs that we thought we had, not so encouraging. Even the procedures that we have that look encouraging, not so good. But I think, again, good vigilance and careful working with your patients can sort of do the best you can with a very bad disease. So thank you very much, and we look forward to, if there are some questions or comments, we would certainly appreciate them. Thank you. Any questions at all? Andy?
Yeah, looking at this anti-muscarinic data in terms of cardiovascular mortality, I've read about this. I'm still confused. What are we posing as the mechanistic thing? Are we talking about tachyarrhythmias or
Right.
animals?
So again, for the filming, the question Dr. Guganti raised was, what is the proposed hypothesis? And if you look at something like stroke, what is it? We don't have an effect on platelet function. They don't have much of an effect on endothelial function. So it probably would come under arrhythmias. And one of the problems that was the FDA threw back in my face when we made the original presentation, that we didn't do enough cardiovascular monitoring. We excluded in those original trials people with significant heart disease. But subsequently, people with heart disease have been studied, and they seem to do pretty good. Everybody got into the UPLIFT study, and we put our worst patients in it. After 4 years, I had 15 in UPLIFT. I only had 4 living at the end. So we put really sick patients in, and all comers. So there is no really, other than cardiac hypothesis like arrhythmias, there really isn't much you can look for to try to explain it. And quite frankly, I was really baffled. I didn't anticipate. I thought that was a really safe drug. Yeah, sure, LABA's okay, and adrenergic drugs, you could increase myocardial oxygen or whatever. So it's hard to explain what it is. Other questions at all? Yes, Phil?
Forever we try to distinguish between severe obstructive disease in which the principal actor is the airways themselves with, fibrosis and other changes, and emphysema in which the effect on the airways is, in a sense, indirect. In these studies that are looking now at air trapping as an important functional parameter that correlates with performance and with symptomatic disease, is there any difference that emerges in the bronchitic type of COPD versus the emphysematous type of COPD?
So Dr. Bromberg raises a question, are there any difference between in some of the newer studies, particularly the CT studies, with the patients who have predominantly an emphysematous phenotype or primarily bronchitic? No, the radiologists, and I've worked with the folks at National Jewish, we look at, for bronchitis, of course, we look at the diameter wall thickness. I think it's of the one of the right-sided, right upper lobe bronchial pulmonary arteries is the usual point of interest, and then of course with the emphysema, like in our Alpha-1 trials, and it's attenuation. I don't think that's been looked at. I think more meaningful though is some of the Jim Hogg looks at the national emphysema patients, where they have both. But I think I don't have an answer to your question, but I think it's a very important one because both can cause, air trapping on CAT scan, very important causes. And it's very, very hard to reverse emphysema, as you know, and people are looking at all trans, retinoic acid, and all these different things. The airway itself, people of statins look like they might have a role on the remodeling of the small airways, perhaps the only therapeutic agent that's really far along in being looked at. But no, I don't know an answer. I think that's an excellent question because there can be tremendous overlap and it can be confusion because of the way the CAT scans look like. So that's a good question. Yes, Rick?
There's been a recent paper bringing back the use of regular antibiotics on periodic intervals, reducing exacerbation rates. Do you see that come back?
Yeah, so that's an important question about regular antibiotics, and the first one would be the macrolide study by the National Institute of Health. The macrolides are very interesting because not only are they good antibiotics, but they have other factors that Rick and Dr. Bromberg would know a lot more about, but they have effects on neutrophil elastase and mucin and things like that. And so, the preliminary studies with the macrolides, I've been watching this extremely closely, really look attractive in terms of reducing the frequency of exacerbation and the mucus burden. I mean, you're the I just got notified you won some award from the ATS, but for your contributions to that area. So you know a heck of a lot more about it by me, but that's my impression clinically that is an effective therapy. Many of these patients, as you guys all know, also have whether there's some bronchiectasis in there as well as the bronchitis, and that's important too in terms of antibiotics. So I think that's a good area to really look very, very carefully at, and that's really where a lot of big trials I think will go in the next 5 years. Clearly what we're doing and what I've told you today hasn't worked. I think that's the bottom line, and we really do need to look outside to other kinds of solutions, whether it's a statin or some other type of agent like antibiotics. I think that's very important.
But as your discussion implies, there are antibiotics that are supposed to be functioning as antibiotics.
Right.
And you'd like to know what are the organisms using modern technology and if there's a real effect on the number of those organisms or on their products
Right.
or their biologic behavior, form, sensing, all that kind of stuff. And the other is that there are antibiotics like azithromycin that may be functioning in a different way.
Correct.
not really as antibacterial agents in the conventional
Right.
sense.
Just one last comment I will make, because you have both really piqued my interest. One thing I was very excited about was, one of the things I do is help companies find pathways through the FDA to get drugs approved. And working with colleagues in Brussels, there's a vaccine for Haemophilus influenza that might be attractive, and a new vaccine for pneumococcus that might be better than the existing polysaccharide-based one that we have. And I would particularly like that type of an approach, and since that might really add some additional value to what what we offer our patients now. So thank you very much.
Yeah, thank you.